I'm Dr. Domingo Molina. I'm an endoscopic spine surgeon. This is a right L5S1 transforaminal discectomy. We will be discussing indications and technique. We'll save targeting and localization for another video. This is a 53-year-old male presented to the clinic with complaints of right hip pain. Patient had exhausted conservative care since 2013, had undergone injections, and was still having pain. He wanted a minimally invasive surgery and wanted to get back to an active lifestyle pretty quickly. So we indicated a right L5S1 transforaminal discectomy. If we look here at the x-rays, you notice the crest is fairly low. So it's a perfect anatomy for a right L5 transfemoral discectomy. I typically check the crest on the AP and laterals. If the crest is below the pedicle of L4, then it's usually amenable to a transfemoral discectomy. If we look here at the T2 sagittal MRI, you notice a little bit of disc bulge into the foramen of the L5S1 disc space. You can notice some ligamentum flavum coming off the SAP as well, so somewhat stenotic foramen. The T2 axial is typically where the money is at. The L5S1 foramen on the right side here, a little bit of a hypertrophic facet. You notice the transforaminal disc herniation, a little bit of a far lateral nature to it, a little bit of a high intensity zone into the paracentral region of the L5S1 disc. So I'll kind of go over my initial starting point for endoscopic transforaminal discectomy. So we used a trans-SAP approach in this procedure. That means docking the jam sheeting onto the kind of most cranial aspect of the supraarticular process of S1, and then advancing reamers down into it. And so what that does is it removes the most cranial aspect of the SAP and enlarges the foramen so we can do most of our work. So what we're looking at here, the cranial aspect of the camera is basically the foramen that I created with the reamers. Right now I'm removing a lot of the fat tissue, epidural fat, as well as just some of the ligamentum flavum from the facet joint. So where we move to now is that you can see the supraarticular process in the upper left-hand corner. I've got the RF probe. I'm checking my pedicle of the S1 vertebral body, making sure that I'm in the correct location. I'm using fluoroscopy and AP plane for this. I'm trying to remove some of this ligament attachment from the facet joint. And that's really what you see on the MRI that I showed initially, and that's where you can get some foraminal compression when people stand. They most likely complain of leg pain when standing, and so the foraminal area of the foraminal area gets smaller and causes compression radiculopathy. And so, as you can see here, this is a perfect view. We remove the supraarticular process tip. There's still some of the supraarticular process that we're going to address. And so what I'm doing right now is just removing some of this fat out of my working view. You can kind of see once I remove the instruments, you can kind of see the canal pulsations come through the epidural fat on the right corner. And so what I'm going to do is I'm going to take the diamond burr and I'm going to remove some of this supraarticular process here in my way and further enlarge the foramina. And so what I do is I kind of like to start kind of inside out, and so what I'll do is I'll advance it kind of where you see here, and then I'll kind of pull it back. And so this is safer rather than plunging into the canal. It gives you a little bit more control because I can kind of feel that lip right there and then pull it back. And like I said, it keeps the traversing nerve root safe. So you can see some of that ligament attachment on the other side. And so again, just kind of removing some of this supraarticular process here. This burr runs at 10,000 RPM, so it doesn't take a lot to remove a lot of this bone. You would think that you'd have to do a lot of bony work, but again, you're working kind of in a small area, and in spine surgery, millimeters count, and so sometimes these patients don't need a ton of extra room, but you do need to kind of adequately decompress all the structures here. Um, so again, still taking the burr here. I'm kind of trying to remove some of that ligamentum flavum attachment with the burr as well. So we'll almost be finished with our burr work here. As you can see, that may be a nerve on the other side of that. You know, it may also still be a little bit of the ligamentum flavum as the lateral recess comes down. So you kind of want to be careful plunging into that area there. I usually use an RF probe to kind of probe the areas to make sure, again, I'm kind of where I need to be. So I always use an RF probe for localization. So almost done with the burr work here. Again, you can kind of see I've taken off a fair amount of the SAP, but not so much that it destabilizes anything. You know, it's a little bit of just experience on how you determine how much you need. I kind of try to access a little bit of the disc space as well through that and make sure that the exiting nerve root is decompressed. So here I take the Kerrison, try to remove some of that ligamentum attachment from the SAP again, and try to just remove any sharp edges. Again, a lot of these foraminal stenosis cases, the tip of the SAP as well as the ligamentum flavum is what impinges on the nerve root, as well as the disc bulge anteriorly. So in this case, you know, we'll talk about the disc herniation towards the end of the case. But right now, my goal is to really decompress the foramina, really get a good idea of where I'm at, maybe visualize the nerve, and you know, again, visualize the disc space. And once I do that, then I can kind of see what else I need to decompress. So again, here I almost got the ligament attachment off, and this is going to kind of really open up our window here for everything. So these Kerrisons, unfortunately, are not super robust, and so you want to kind of do most of your bony work with the burr if you can. The Kerrisons are not the normal size Kerrisons unless you're using the older traditional Joymax probe, or excuse me, a working tube. So again, here's my pituitary. I'm removing a lot of this. This ligamentum was really sticky, so it was really hard to remove a lot of this. Another question may be, well, how do you know what you're grabbing? Well, as long as I stay within my working tube, I know where the nerve is. I know that the exiting nerve is to the right of the working tube, protected under the kind of near the pedicle. I know that I'm right under the SAP, and so anything within my working tube I can grab. As far as depth, I know that I'm not in the canal, so again, you kind of want to not try to stray out too far from the working tube. There are certain bites that I do use that for, but again, I kind of really know where I'm going. And so here in the bottom corner, you can kind of see this is where the case gets interesting. This patient ended up having a calcified disc herniation. I don't typically get CT scans on lumbar cases. It's probably a good rule of thumb if the patient has had radicular symptoms for even more than a year or close to a year to probably get CT scans. I'm pretty comfortable that once I get in there, it's not really going to change my treatment. I'm going to either shave down the calcified disc and open up the foramen. A lot of these patients I don't indicate a fusion on, and I'm doing this endoscopic case just solely to, you know, for conservative purposes. So I'm going to do some sort of decompression, again, whether it's a soft disc or a calcified disc. Some people may agree with that, some people not, but I think that's a nice thing about the Joymax is the ability to do that. So we'll kind of fast forward for time purposes here. So we've already removed the tip of the supraarticular process. I'm using the RF probe right now to try to localize actually where the disc space is. And so in this case, you know, I took a AP radiograph, I took a lateral radiograph. I'm trying to check where the pedicle is. I know that I'm over the disc space. And so I'm really just trying to be careful and kind of figure out where I'm at. You can kind of see some of the traversing kind of epidural veins, as well as the traversing nerve root is right behind that. So sometimes it's a little bit hard to differentiate some of these structures. You know, you can kind of use the bipolar setting rather than the vape setting and kind of touch it to any of the structures to see if you get any EMG activity. I do monitor all these cases with EMG, and so that's always good to do. So here I'm kind of looking at the joint, kind of seeing it move, making sure I can, again, visualize where I'm at on my head. There's still a little bit of ligamentum attachment. I'm not too apt to get this. I'm trying to kind of remove it with the vape setting on the RF probe. Again, traditionally you should kind of see the traversing nerve in the canal. This patient did not have lateral recess stenosis symptoms. So again, I'm really trying to clean up the foraminal window, rather than the lateral recess. Sometimes using your trajectory is good and bad. If your trajectory is too high, if you come in kind of too cranial to caudal, then you won't be able to ever get into the lateral recess. I've had this situation before, and so here I'm kind of putting in a lot of these slides to show you really truly how I do this, and try not to leave anything out for people that are just getting into endoscopic spine surgery. And so, you see a lot of bleeding here. What I do is I kind of push the camera down really close to the pathology, and that'll kind of help me try to visualize where the bleeding is coming from. I use epi in my bags of saline. I actually just started doing that. It's been a world difference. So what I'll do is I'll take the bipolar probe, kind of probe around here. What I had done is I had stuck the RF probe kind of too ventrally, and if you know from open procedures, that's not good, because that's kind of where you get into those really brisk bleeders. And so eventually I was able to control it, sticking the RF probe down in there, and you kind of want to really hold it over what's bleeding too. I know that seems a little bit intuitive, but sometimes it's not when you're actually doing this in a person. So sometimes even some of these bleeders from this epidural fat can really get you. So it's really important to get those too. Again, I don't know if you saw a hint of the exiting L5 nerve root there on the side. That's the nice thing about the Joymax cameras, you can really see it. And so if you look here, I finally was able to kind of figure out the disc space. It's calcified. I'm kind of removing some of this fat, but if you saw, I could press with the RF probe, and the annulus was kind of moving a little bit. It's a little bit spongy still, but definitely a calcified component to it over it. So what I'm going to do is, here at this point, I was kind of thinking, well, do I just leave the decompression as it is, or do I go ahead and take the diamond burr and decompress it? So at this point, I'm using the diamond burr to decompress the calcified disc. I'm basically just removing enough that way I can get into the disc space a little bit, remove some of that far lateral kind of transforaminal component that we had seen. In a minute, we're going to take a look at the exiting nerve root, but I do know that the exiting nerve root is free. And so how much do I remove here? Honestly, it's just kind of a guess. I'm using fluoroscopy in the lateral plane to check my depth. I'm going to see here, I kind of start moving the disc space a little bit, checking for the annulus, because I know that the whole thing is not totally calcified. And so I can see a little bit of some fibers of the annulus there. And so I know that the SAP was really the main culprit, as well as the hypertrophic ligamentum flavum attachment off of the SAP. And so I'm not going to spend too much time doing this. I'm already towards the end of the case here, but just want to, again, make sure that I do have a thorough decompression. That way when the patient stands, he doesn't have any radicular symptoms from the compression and the decrease of the foraminal area. So I'm getting a little bit far out here. How do I know that? I just know that where my working tube is. I don't want to stray out too far laterally, because you always kind of want to keep the working tube where you can recognize the anatomical structures and know where you're at. So you can see here we're getting more of the annulus fibers here. The disc is pretty chalky, and so that's what I'm removing with the diamond burr here. I am in a disc space here. I'm taking fluoroscopic shots at the same time that you can't see, but I'm checking my depth, just to kind of, one, annotate that I'm in a disc space, and then two, making sure that I do remove enough of the disc space. just to have a good thorough decompression. So this time I'm using my pituitary to remove some of the calcified disc and some of just the chalky annulus fibers. I'm not going to spend too much time doing this because again, that's not really the main culprit of my compression. Especially since it's calcified, I know that if the patient continues to have radicular symptoms, I'll talk to him about possible fusion later. But again, I've had several of these cases where usually decompressing a calcified disc and doing some of the bony work really alleviates a lot of their symptoms, and we can get them out as far as possible before having a fusion. But I do counsel them post-operatively and say, hey, the disc is calcified, the level's very degenerative. We did take care of your symptoms now, but there may be a fusion in your future. I had a guy with a L4 quad palsy that after my decompression, I wasn't so sure that I'd gotten everything just because of the degenerative nature. But again, he ended up getting full quad function back. He was 86, I believe. And so, again, I control some of his bleeding again with the RF probe. You want to make sure that you control some of the bleeding just to make sure you don't have any epidural hematomas. Following that, I have had a couple of cases where the water pressure will kind of stave off some of the epidural bleeding, and then you take the tube out, and then later on they have continued radicular symptoms, or they have an epidural hematoma because there wasn't as much bleeding as you thought there was. So this is kind of where we kind of check our decompression. Again, I didn't get really into the canal here. I still haven't in my cases really, unless they have lateral recess symptoms, really spent a lot of time decompressing that area, mostly because I don't like to take blind bites into the canal there's usually a lot of epidural fat, but I can see the canal pulsations there. You can see here that the SAP is removed, or at least the tip of it, and this is a great view of the L5 exiting nerve, and so I couldn't be happier with getting this decompression. I know that his radicular symptoms are most likely going to be gone because, again, he's got a ton of room in here now for the exiting L5 nerve root. There's a little bit of some disc right there, and so the great thing about the working tube is that I can kind of push the nerve out of the way. I didn't want to go the other way, so I'm coming back this way because I don't want to squish the L5 nerve or compress it. I guess squish is a medical term. But, the L5 nerve can sometimes be very tenuous, and so I don't want to push on it too much. Again, this is just kind of an experience feeling on how much to retract a nerve root. Again, I'll use a pituitary to remove that little bit of some disc there again. And so, again, really not going to spend too much time going into that corner because even though you can kind of see it, you don't want to get too far into there because the nerve does take a pretty oblique angle at the L5 S1 disc space. And so that's really been evident when I've done these cases, really to learn the anatomy of the exiting nerve root. And so, it's been really great to actually see, well, how does the L5 nerve root travel? So again, great view here. Everything's decompressed. The SAP is removed. I removed some of that calcified disc. The L5 nerve looks great. It's free and clear. I know that when this patient gets up, he's not going to have any ridiculous symptoms. This foraminal area is going to collapse a little bit when the patient stands up. And so again, that's where some of that hypertrophic ligamentum flavum and that facet or the SAP can really compress on that nerve root. And so you can imagine that if the full SAP was there as it was initially, you can understand now how it can be compressed and cause radicular symptoms. So that was the end of our case. Thank you for watching and listening. I'll try to post some more of these videos on kind of new techniques for people that are getting into endoscopic surgery. The patient did have a complete alleviation of his radicular hip symptoms and pain down the right lower extremity. Following that, less than a 1 centimeter incision, sent patient home approximately an hour and a half after surgery. So my post-op protocols are typically no extreme heavy bending, twisting, or lifting for a couple of weeks. And the patient can, especially if there's no disc component to it, they can get back to activity a little bit quicker. If anybody has any questions, just send me a message and I'd be happy to either give advice or explain things further. Thank you.